Hello everyone, Stefan Hartman here, IronDPC.com, bringing you my latest lecture on the evidence for testosterone replacement therapy in men. And why do we have to go over this? Well, we didn't learn it in our medical education. PAs, NPs, MDs, DOs, we don't learn testosterone replacement therapy for really any purpose, especially not anti-aging purposes. And it's oddly controversial as well. Fortunately, I'm doing a new training with the Board Certification of Anti-Aging Medicine, which is oddly enough controversial in itself. But we're going to go through the evidence for this and see that testosterone replacement therapy in men is really evidence-based, and it can prevent and treat a lot of diseases. There is more and more guidance coming out. Time for international action on treating testosterone deficiency syndrome. So we're having more call to action on this. We're seeing that about 20% of men over age 50 in the general population are expected to have testosterone deficiency symptoms. In America, we are kind of leading the way in treating this. About 7% of these men are getting treated, but in other parts of the world, they are not treated and they are suffering. One of the big myths I can encounter a lot among my colleagues is testosterone replacement therapy causes heart attacks and prostate cancer, and both are false. So, there is no evidence that administration of testosterone can induce the appearance of prostate cancer if it is non-existent. So, despite the historical reluctance towards the use of testosterone therapy in men with a history of prostate cancer, modern evidence suggests that testosterone replacement is a safe and effective treatment option for hypogonadal men with non-high-risk prostate cancer. So we're having two different studies here showing that testosterone replacement therapy doesn't cause prostate cancer in men without prostate cancer in the first place, and that we can even use testosterone replacement in prostate cancer survivors. A lot of this studies is done by Dr. Morgenthaler. I don't think either of these done by him, but he does a lot of this research as well, and he is using TRT in men who are prostate cancer survivors. So very cool stuff being led through him and his research. See if I can go to the other one. The concept that TRT causes heart attacks when actually the opposite is true, and low testosterone is associated with increased risk of having heart attacks. And why is this? So due to conflicting evidences related to TRT, cardiovascular disease and mortality, the US FDA has warned that TRT might increase heart attack and stroke. A critical review of the published systematic reviews found that 2 out of 6 systematic reviews and meta-analysis showed increased CVD risk with TRT. However, recent reviews show that there is a trend towards reduced major adverse cardiac events, all-cause and cardiovascular mortality with TRT, with the greatest benefit seen in men at highest risk of cardiovascular disease, such as those with type 2 diabetes and metabolic syndrome. Moreover, greater benefits are observed among those treated to the target for longer duration. A recent published population-based observational study showed that longer duration TRT is associated with decreased mortality, cardiovascular disease events, and prostate cancer, whereas shorter term duration TRT increased mortality and cardiovascular disease events. Very cool stuff. Glad we're doing the research on this. So more on this subject. Several studies point to an association between testosterone levels, triglycerides, and hypertension. Moreover, low testosterone is strongly associated with type 2 diabetes, given that 1/3 of men with type 2 diabetes have secondary hypogonadism. Yao et al. Performed a systematic meta-analysis and concluded that higher testosterone levels in men can significantly decrease the risk of type 2 diabetes. Long-term testosterone therapy in hypogonadal men prevents the progression of prediabetes and achieves type 2 diabetes remission. However, the benefit-risk balance of long-term testosterone treatment is unclear in men with type 2 diabetes. These associations suggest that testosterone is a component of the metabolic syndrome, which I've discussed previously, a cluster of risk factors including abdominal obesity, dyslipidemia, hypertension, and insulin resistance. Hence, testosterone replacement therapy is sometimes an adjunctive therapeutic option for metabolic syndrome, which I believe very strongly in. You can listen to my whole lecture on this subject, how a MASH, male-associated hypogonadism, is associated with metabolic syndrome. This study looked at the effects of oral testosterone treatment on myocardial perfusion and vascular function. Now, I don't do oral testosterone. I think it has a little liver toxicity, but this is what this study did. Men aged 40 to 75 years with angiographically proven coronary heart disease, greater than 70% lesion in one or more major coronary arteries. 22 men, mean age about 60, were randomly assigned to oral testosterone undecanate 80 milligrams twice daily or placebo. Testosterone undecanate did not significantly change serum testosterone or estradiol. However, percentages of free and bioavailable testosterone and dihydrogen levels increased. Conversely, testosterone undecanate treatment was associated with a significant decrease in sex hormone binding globulin, FSH, and luteinizing hormone. Global myocardial perfusion was not significantly different. However, myocardial segments supplied by coronary arteries without significant obstruction showed significant improvement in myocardial perfusion index of the subendocardium. Testosterone undecanate treatment was associated with significantly lower high-density lipoprotein cholesterol and apolipoprotein A1 and higher HDL lipoprotein, low-density lipoprotein ratio compared with placebo. Apolipoprotein A1 apolipoprotein ratio decreased with borderline statistical significance, and glucose and insulin were not different between treatments. Testosterone undecanate treatment decreased basal, peripheral, and central arterial stiffness, and concurrently, there was a comparative increase in left ventricular ejection fraction. There was a null effect on overall myocardial perfusion and global endothelial function, quality of life, and angiogenesis compared to placebo. So this study showed that your arterial wall stiffness, which is known to be a factor in high blood pressure, improved with testosterone therapy. That in itself is significant, right? We don't have many other methods to soften the arterial walls. Testosterone and heart failure. The data showed that testosterone supplementation, given in addition to optimal medical therapy, improves functional capacity, large muscle strength, and glucose metabolism in elderly patients with congestive heart failure. The increase in functional capacity and muscular strength is related to an increase in plasma levels of testosterone and not related to changes in left ventricular function. Much evidence has suggested that testosterone replacement therapy may be beneficial for older persons with heart disease. However, a recent article in New England Journal of Medicine suggested that testosterone therapy was harmful for frail older persons. This article failed to put its results into context with multiple other studies which have shown no major negative effects of testosterone on the heart. The authors also used edema as a sign of heart failure, apparently being unaware of the common causes of edema in older, frail persons. These include low albumin, low red blood cells, varicose veins, decreased muscle strength, and decreased activity. Testosterone also acts as a calcium channel antagonist, which results in edema. Testosterone clearly causes water retention, which would aggravate peripheral edema. Finally, it should be recognized that frail older persons are very likely to have a variety of events unrelated to therapeutic interventions. So here we're seeing testosterone can help patients with heart failure. And we know very well there's very poor treatment for heart failure once it's progressed beyond a heart transplant, right? That's how you revert heart failure. You can do optimization with beta blockers, you can put them on an ACE inhibitor, you can do all these medications that oftentimes make you dizzy and feel worse. But here we're seeing testosterone can help as well. Testosterone with basically no adverse heart effects. And not many adverse effects at all if you're an older male with heart failure. Does T replacement reduce hospitalization and death? A meta-analysis was conducted of 19 testosterone replacement studies in which 651 persons received testosterone and 433 placebo. There were 18 cardiovascular events in the testosterone group and 16 in the placebo group. Arrhythmias were slightly more common in the testosterone group, but this was not statistically significant. Heart failure was not a problem in the testosterone-treated group. In a retrospective study, Hajar et al. Found a decrease in cardiovascular diseases in males treated with testosterone. A total of 11 placebo-controlled studies have examined the effects of testosterone in males with either cardiovascular disease or frailty. In these studies, the mortality was higher in the placebo-treated group. While heart failure was slightly more common in the testosterone-treated group, this appeared to be predominantly defined by the presence of ankle edema again. In the study by Caminti et al., heart failure did occur but was easily treatable with slight increases in furosemide doses. Again, they qualified heart failure as ankle edema, which we referred to in the previous article as being a non-specific marker of heart failure. But what did they find at the end there? Chapman et al. Found a decrease in hospitalizations in frail males and females receiving low dose testosterone. Sexual health, we're not going to get too much into that, but we know that does help. Muscle wasting and strength. So again, interestingly, these were very sick populations. These are not bodybuilders. And what they found here is that in these sick populations, they didn't increase their muscle mass, which we know, obviously, if you utilize testosterone with a progressive resistance training program, bodybuilders really know this. Just look at Arnold Schwarzenegger. Yes, he used testosterone. He used a lot of things, by the way. You're going to gain muscle mass. But they looked at these very sick populations. So HIV, muscle wasting diseases, patients with cancer, COPD, CHF. They were looking at these specific, very frail people who traditionally we're like, oh, you can't give them testosterone and they'll get a heart attack, which we know isn't true. We're looking at these previous studies. So look at what did they do here? Let's see what they do. So needless to say, they used testosterone in these populations. There weren't any adverse effects. Maybe they showed some improvement in muscle strength. T on psychiatric symptoms. Mixed reviews on this. I haven't really seen too much evidence to support testosterone therapy for psychiatric symptoms, but really it's going to be patient specific. I'm going to use this on a case-by-case scenario. If I have a depressed male with a low testosterone, we have to bring this testosterone up and then address the psychiatric issues. Maybe it is a neurochemical imbalance of the brain, but hey, it might be related to the obviously endocrine imbalance from a low testosterone. So we would treat the low testosterone first, and then we would address to see if maybe we need to address with further chemicals for targeting the brain and the neurotransmitters there. Summary of meta-analysis. Substantial evidence supports favorable effect of testosterone treatment on muscle mass in both healthy males and men with HIV, and a majority of studies show a decrease in fat mass. Testosterone did not affect most measures of muscle strength. While decreasing frailty and increasing strength in older men might be beneficial, testosterone supplementation does not improve physical function of older men. Obviously, you need to do a progressive resistance training program. Testosterone by itself isn't going to give you big muscles. So that's the one thing the bodybuilders do get right. They're like, bodybuilders are like, oh, it's not the juice that I'm using. It's all the hard work I put in the gym. Yes, you're putting in a lot of hard work, but you're able to do that thanks to really quick recovery, thanks to high testosterone or super physiologic doses of testosterone. So these studies that show that maybe the HIV man treated with testosterone didn't gain muscle, were they really doing a structured progressive resistance training program, progressive overload? I don't think these studies actually showed that. So, yes, it is safe to use in very sick individuals. Apparently, according to these studies, these sick individuals aren't doing a strength training program. My conclusion is that we can use testosterone therapy in an older, frailer population very safely, and possibly they could start a progressive resistance training program, and then we could see twice the benefit with testosterone replacement. Testosterone replacement therapy in obesity. So obese men with secondary hypogonadism achieve statistically significant reduction in fat mass, increase in lean body mass, and A1C improvement, associated with 52 improvement in beta cell function with testosterone replacement therapy. Treatment also resulted in overall improvement in metabolic state, including improvements in the following parameters: BMI, waist circumference, lipid profile, blood pressure, lipoprotein A, hemoglobin, fasting glycemia, insulin resistance, and leptin resistance. TRT also reduced arterial stiffness, respiratory quotient, hepatic fat content, and bone remodeling. TRT mediated and psychotropic effects included improved energy and motivation. Weight loss associated with TRT was almost exclusively due to loss of fat mass, whereas the weight loss due to dieting is from loss of both fat mass and lean muscle mass. Although TRT did not augment diet-induced loss of fat mass, it prevented diet-induced loss of muscle mass. So these favorable effects of TRT on body composition may be due to androgen receptor signaling in adipocytes and myocytes, which are fat cells and muscle cells, and or increased physical activity seen in testosterone-replaced men. However, successful visceral fat loss achieved by testosterone therapy is not maintained after cessation of TRT, as low testosterone after TRT withdrawal may lead to fatigue and inertia and less physical activity. That suggests that long-term TRT is required to maintain beneficial effects. So some of my patients may be like, oh, I don't want to be on TRT forever. Well, listen, you're 50 years old, you're not having the testosterone of a 20-year-old anymore, and it's just going to decrease with age. We saw the charts earlier. It drops off with age. The older you get, the lower your testosterone gets. Now, what happens with low testosterone? Basically, a lot of the problems we see with aging. Arterial wall stiffness being one of them, high blood pressure, right? Well, we can't reverse aging, but we can perhaps treat some of the pathological parameters of aging with TRT. So one, you could be on 10 different medications to lower your blood pressure, to treat your depression, to treat your arterial wall stiffness, to help you with weight loss, to help with your libido. Maybe that's 7 medications already. Maybe we could try some testosterone and see if it could fix these 7 parameters. Maybe it can't. Then we can address those parameters afterwards. But that's my point here, is that instead of giving you 10 different pills to treat 10 different things, we treat it more at the root cause, which is what Iron DPC is all about, is treating the root cause. And yes, we like a holistic approach to things, nutrition, supplementation, exercise, but that really only gets us so far as we age. At a certain point, we do age. We have to recognize that, but we can treat it with safe and effective pharmaceutical intervention, namely TRT replacement, or TRT, testosterone replacement therapy. More on TRT and weight loss. I think we hammered that one in. Hormone replacement therapy and longevity. That's what I'm all about. I'm doing the board certification in anti-aging medicine. This is where we talk about hormones and its role in anti-aging and longevity. And yes, we are seeing more and more studies showing this, that maybe improving your life quality and possibly improving your lifespan. Maybe just by the fact that you don't fall down from frailty and hit your skull. That could be a one way to extend your lifespan. Yes, muscle mass is integral. I think muscle is the most important organ we have. It controls everything. It controls our skeletal frame. It controls how quickly we burn fat. It controls our brain. As you build muscle, you build neural connections in your brain. That's why I feel so strongly about muscle mass in men. A couple negative side effects with testosterone replacement. Yes, you can get higher estrogen, because if you increase your testosterone, it may be converted into estrogen. We just monitor this with some blood work. It doesn't always happen, but if it does happen, we can use androgen receptor modulator, aromatase inhibitors. We use aromatase inhibitors to stop that process of testosterone being converted to estrogen. We can use serums. We can use maybe just topically some level of serum. So that is possible if this does happen. Obviously, we're not going to look like Bill Gates because we're not sitting around eating vegan burgers. Alopecia with TRT, very interesting here. Yes, it can happen. So men ask me, will I lose my hair if I start TRT? Look at your hair, look at your dad, look at your grandparents. Are they balding? Are they bald already? Do you have a genetic susceptibility for hair loss? If you do, there's a chance you might lose your hair. But this is due to DHT, and we could possibly block DHT with medications and supplements. So there's that. Now the FLCCC, there's one study I wanted to bring up here, is that men suffering with COVID, because we can't say it correctly here or we get censored. Men suffering with COVID in the hospital, with a low testosterone are more likely to have a bad time with COVID. Men, in this very interesting study you can see here, men with androgenic alopecia, so male pattern baldness, also do worse with COVID. Now, my friends in the FLCCC, they've been using spironolactone to treat men hospitalized with COVID, and this suppresses overall testosterone. I'm not a huge fan of this, clearly. But I think that a focus more on dihydrotestosterone, DHT blocking, could prove beneficial. So that's where I would focus most attention. Perhaps instead of spironolactone, let's focus our attention on maybe finasteride or saw palmetto to block the DHT, because perhaps that could be a target we could utilize. But besides that, perhaps increasing free testosterone in men, improving their muscle mass, improving their resiliency to infection in the first place, getting them on an exercise program might be more beneficial than waiting till they get to the hospital and then blocking their androgen receptors. Conclusions: TRT is under recognized therapeutic modality. TRT is not a cure-all for advanced diseases, but it may improve some level of heart failure and hypertension. So that's pretty cool. TRT will help retain muscle mass and frailty and advanced disease states, HIV, Parkinson's, advanced cancer. TRT does not cause heart attacks and does not cause prostate cancer. Conversely, which some of my medical colleagues may be surprised to hear. On the other hand, hypogonadism is associated with increased prostate cancer, interesting enough, and increased risk of heart disease, heart attacks. So low T must be treated. TRT prevents hospitalization and death in men with cardiovascular disease and frailty. TRT most likely improves sexual health in men. TRT on psychiatric symptoms in hypogonadism is mixed. For my conclusions, I would expect the greatest benefit with TRT to be men who are already maximizing their nutrition, resistance training, sleep, vitamins, etc., but still have low T. Once advanced disease states are achieved, the benefits with any therapeutic is minimal or moderate at best. TRT may cause alopecia in genetically susceptible individuals. Low T men with higher fat mass do worse with COVID. Androgenic alopecia men do worse with COVID. Specifically blocking DHT can save hair loss and possibly aid in fighting COVID rather than using spironolactone. But I would argue, let's get men healthier in the first place, get them in the gym, making them feel better about themselves, and they won't end up in the hospital in the first place with COVID. So that's all I had for you today. I hope you guys liked this lecture. Please like and subscribe. Follow me on Iron DPC, Iron Direct Primary Care, Instagram, Facebook, and check out my new book on Amazon, The Alpine Ring. See ya.